alpha-1 adrenergic receptor. And in the same way on arteriolar smooth muscle there are mainly alpha-1 adrenergic receptors on most of the arterioles, because on the skeletal muscle arterioles they have dominantly beta-2 adrenergic receptors. Now we will talk about next group of sympatholytic drugs, right? We have already discussed one group was, yes, centrally acting sympatholytic drugs. Second was ganglion blocker. Third was sympathetic nerve ending blocker. Now we come to the fourth group of drug. They are sympathetic receptors blocker. You can say adrenergic receptor blocker drugs. They are adrenergic antagonists, right? Already we have discussed that adrenergic receptors are alpha receptors and beta receptors. We have discussed alpha-1 receptors. Adrenergic receptors are mainly on, yes, veins and arterioles, and beta-1 receptors are mainly on the heart. Is that right? Now, the adrenergic receptor blocker drugs, some of them are alpha-1 blocker. Some of them are alpha-1 receptor blocker. Let's suppose that we use a drug which is alpha-1 adrenergic receptor, yes, antagonist. Alpha-1 adrenergic receptor antagonist. Do you know now? Alpha-1 adrenergic receptors antagonists, what they will do? They will block here. This is mechanism number 4. Right? That this drug will block the alpha-1 receptors on the veins as well as will block the alpha-1 receptors on the arteriole. Now it's so easy to understand. If we give alpha-1 blocker drugs, then sympathetic activity on the veins is inhibited. Venous smooth muscle is inhibited. Veins will dilate. Venous return will be reduced. And if venous return is reduced, end-ventricular filling is reduced, and end-diastolic volume is reduced, and stroke volume reduced, cardiac output reduced, and systolic blood pressure is reduced. Secondly, when alpha-1 receptor blocker drug act on arteriolar smooth muscle and block the alpha-1 receptors, then arteriolar smooth muscles also relax. So there is arteriolar dilation. And when there is arteriolar dilation, that will lead to what kind? Total peripheral resistance. The resistance to the blood flow is reduced and diastolic blood pressure comes down. So you understand how the alpha-1 receptor blocker works. But here I want to highlight one thing. That when we concentrate really on the concept of alpha adrenergic receptor antagonists or blockers, right? There are two groups of these drugs. There are non-selective blockers, and there are, yes, selective blockers. Non-selective block alpha-1 receptor as well as they block alpha-2 receptors. And selective blocker drug block only alpha-1 receptors. Is that right? So it means alpha-1 receptor blockers are two types of drugs. Some block alpha-1 and alpha-2 both, and some drugs only block alpha-1. Right? We have to see which one are superior drugs. The drugs which block alpha-1 and alpha-2 both, they are called non-selective alpha blocker. Example is enoxybenzamine and phentolamine. Enoxybenzamine and phentolamine. And block only alpha 1 receptors. They are, yes please, who will tell me the name of the drugs which are alpha 1 blocker, but not blocking the alpha 2? Anyone? Yes? Alpha 1 blockers. Selective alpha 1 blocker, they don't block alpha 2. Right? Prazosin, have you heard of prazosin? Prazosin, doxorubicin. So, prazosin and doxorubicin. These are very commonly used drugs, but these are not commonly used. Alpha 1, selective alpha 1 blockers are superior drug for use in hypertension to bring the blood pressure down. Phenoxybenzamine and phentolamine do bring the blood pressure down, but they are not very good drugs. Why? No, there is some special reason. Okay, let me explain before you tell me something totally new. Right? Listen. Let's suppose this is your heart, right? And here is your venous system. You take the blood to the heart, and of course here is your arterial system. It's a very simple diagram, dangerously simple diagram, right? Now listen carefully. This is sympathetic nerve ending to the heart. This is sympathetic nerve ending to the vein, and suppose here is a sympathetic nerve ending to arteriole. Let's suppose these are the receptors. Now this is,
अगर आपका बिजनेस हर दिन आप पर डिपेंड करता है तो आपने अपने लिए बिजनेस नहीं बनाया, अपने लिए एक सेल्फ ट्रैप क्रिएट कर रहा है। मैं बोल रहा हूँ अगर बिजनेस आपके बिना नहीं चल पा रहा है तो आपका बिजनेस जो है वो ऑलरेडी ब्रोकन। हमने अपने पुराने बिजनेस को 245 करोड़
alpha 1 adrenergic receptors. This is alpha 1 receptor. Here is also which receptor? Alpha 1 receptor. What is the receptor here? Yes, please. Beta 1 adrenergic receptor. Now all these nerve endings are releasing norepinephrine. They are releasing, yes, norepinephrine. They are sympathetic nerve endings, no? All of them will release norepinephrine. Arteries and veins have mainly alpha 1 receptors and heart has beta 1 receptor, but all of them have auto inhibitors. What is this? Alpha 2 receptors. There are also alpha 2 receptors. Here are also alpha 2 receptors. Clear? Now listen carefully. If we use, for example, phentolamine or phenoxybenzamine, which block alpha 1 and alpha 2 both, what will happen? Before that, first you understand a very, very basic concept. The basic concept is that whenever you do alpha blockade, you block the alpha 1 receptor, veins will dilate, arterioles will dilate. Is that right? And what will happen? That blood pressure will fall. Blood pressure will fall. Venous return to the heart will be decreased. Again, listen first of all carefully. First, I tell you the basic. Do you know the mechanism of orthostatic hypotension? Have you heard of the term orthostatic hypotension or postural hypotension? Or let me tell you exactly what happened. First, I'm going to talk about physiology, normal physiology. Then I will apply that on the drug use. Let's suppose this is a normal person lying on the bed. He has not taken any drug. And this person is absolutely healthy. He is lying on the bed. If you suddenly stand up, gravity will pull the blood down. So there are chances when you stand up from the bed, morning, when you suddenly stand up from the bed, chances are there that gravity is preventing the venous return to the heart. So blood will pool into veins of the lower part of the body. Blood has a tendency to pool into, to accumulate into lower part of the body. But actually what happens, as soon as you stand up, right, blood pool down, a little pooling, then venous returns slightly down, cardiac filling slightly down, cardiac output slightly down, then baroreceptors report to the medulla that blood pressure is falling, and medullary vasomotor center fire sympathetic system, and that sympathetic system squeezes the veins in the legs, and that squeezes the veins in the legs so that venous return should be maintained. Are you understanding me? What I'm talking about? This is a normal thing. That on standing, your blood has a tendency to pool into lower part of the body, but thank God sympathetic nervous system fires and constricts the veins and prevents the pooling of the blood and maintains the venous return to the heart. Claro? Right. Now we come to a person who has been given a sympatholytic drug. A person in whom sympathetic system is not working well. For example, you have given alpha 1 blocking drug. A person who has been given alpha 1 blocking drug or sympathetic nerve ending blocking drug. Now such person from lying down position, if you suddenly stand up, sympathetic system will fire in the central nervous system. But can norepinephrine act on veins? No. Either nerve ending is failing or alpha 1 receptors are blocking. So, do you think veins will constrict or remain dilated? So, blood will pool into lower part of the body. Venous return will become sure very less. Cardiac output will become very less. And cardiac output will be less. And on standing, your systolic blood pressure will dramatically drop. But patient will not come and tell you, doctor, you see my systolic blood pressure is down. No. Patient will come to you, doctor, I don't know, you gave me the drug, and when I wake up in the morning or whenever I stand up, I feel vertigo. Because blood going to the brain is less, so he feels vertigo. Or he feels blackout. Or sometimes even they fall down, patient, due to that. This is a result of hypotension which is produced due to sudden change in the posture when sympathetic nervous system is not working. This type of hypotension is called postural hypotension. Another name for this hypotension is called orthostatic hypotension. Another name for this hypotension is hypostatic hypotension. Is that right? So all those drugs, we don't allow the veins to constrict on standing, produce a side effect of what thing? Postural hypotension. Postural hypotension. Whenever there is postural hypotension, naturally, normally, listen, normally when you stand up, sympathetic nervous system fire. Is that right? Veins constrict and heart rate also go little up. Is that clear? After understanding this thing, now we come to the back to this diagram, right? Let's suppose you have given a person alpha 1 blocker as well as alpha 2 blocker. Is that right? Advantage of giving alpha 1 blocker is what? You give the alpha 1 blocker, veins relax, arterioles relax. When veins relax, venous return become less, cardiac output become less, systolic blood pressure come down. When arterioles relax, total peripheral resistance is reduced and diastolic blood pressure come down. This is what we wanted. We are happy about it. But there are few things which are making us unhappy. What is the unhappy thing? That once you have given alpha blocker, veins cannot respond to the sympathetic overflow on standing. Or can they respond? When you have given alpha 1 blocker, do you think when from lying down position you suddenly stand up, sympathetic system will fire? But do you think veins will constrict? No, because no, in a person with drug, no, and he will develop orthostatic hypotension. This is one problem with alpha blocker, right? But with alpha 2 blocker, there is a very special problem. You know what is that? When you do use this group of drug, you are blocking alpha 1 as well as you are blocking alpha 2. Is that right? Alpha 2 receptor was inhibiting the release of, it was auto inhibitor. When alpha 2 receptor is stimulated, there is less norepinephrine. And if alpha 2 receptor is blocked, nerve ending assume that it has not released any norepinephrine. So it will release extra. Now listen very, very carefully. When alpha 2 receptors are the eyes of the neuron, that when neuron releases norepinephrine, some norepinephrine work on alpha 2 receptor, right? And nerve ending can estimate how much norepinephrine it has released. If it has released too much, then alpha 2 receptors are too much stimulated and it does not release further norepinephrine. It is auto control, auto inhibition. Clear? Now listen. If you have given drug, phentolamine or phenoxybenzamine, alpha 2 receptors are also blocked along with the alpha 1. Is that right? What will happen to this nerve ending? If this receptor is blocked, a little norepinephrine which is present here, can this norepinephrine stimulate alpha 2? No. So this neuron will assume if there is no alpha 2 receptor stimulation, it means there is no norepinephrine. It will release less or more? More. Now, when you give phentolamine and phenoxybenzamine, when alpha 2 receptors are also blocked, all sympathetic nerve endings start releasing excessive amount of norepinephrine. This extra amount of norepinephrine cannot work on veins because the receptors are blocked. It cannot work on arteries because the receptors are blocked. But when this is blocked and the release starts, beta 1 receptors are not blocked. Beta 1 receptors are not blocked. So it means that extra release of norepinephrine due to blockage of alpha 2 receptor drives the heart mad. In these patients, the severe tachycardia. They said, doctor, what type of drug we have given? We have double problem. From lying down, when we stand up, our heart rate goes up and we develop blackouts and vertigo. At the top, because norepinephrine, our heart is going crazy. Without seeing any beautiful girl, our heart is getting crazy. They all the time they feel what they feel. They feel palpitations. Palpitations are, how do you define palpitations? When you can feel your heartbeat. Look, in romantic literature, your definition is right. But in medical literature, look, in medical literature, palpitations are defined as unpleasant awareness of your own cardiac activity, unpleasant awareness of your heart activity. For example, if you do exercise and you feel your heart is boom, boom, it is good. Or if you are under some very intimate relationship, your heart races up. Do you think you will go to doctor and you will say, I want treatment? No. But if someone's sitting and heart is boom, boom, it is healthy or unhealthy? It is unhealthy. That is palpitation for which you will go to the doctor. So what is palpitation? Palpitation is unpleasant awareness of your heartbeat. Right? So what happens? This person, where alpha-2 receptors are blocked, norepinephrine is released too much by the sympathetic nerve endings, right? Maybe norepinephrine release in veins and arteries is not producing any problem because alpha-1 receptors are blocked, but unfortunately, on the heart, beta-1 receptors are not blocked, so excessive release of norepinephrine due to alpha-2 receptor blockage, excessive release of norepinephrine produces severe tachycardia in the heart. The patient develops palpitations. So, this is the problem with phenoxybenzamine and phentolamine, because they block not only alpha-1 but they also block the alpha-2. And any drug which blocks the alpha-2, it increases sympathetic nerve ending activity. Do you remember? Clonidine and alpha-methyl dopa, they were actually not blocking alpha-2, they were overstimulating alpha-2. So don't get confused. Centrally acting drugs were overstimulating alpha-2 so that sympathetic nerve endings are inhibited.
मैं सिर्फ 3 घंटा आपसे मांग रहा हूँ। इस 3 घंटे के अंदर मैं आपको एडवांस एक्सेल के फॉर्मूलाज के साथ एआई और चैट जीपीटी हैंड्स ऑन प्रैक्टिस के साथ सिखा दूंगा। तो एक हाई पेइंग सैलरी के लिए, बहुत बड़े प्रमोशन के लिए आपको आना चाहिए एडवांस एक्सेल के साथ एआई और चैट जीपीटी का सही इस्तेमाल करना। लेकिन 10 में से 9 लोगों को पता ही नहीं।
But here our drug is blocking alpha-2. Is that clear? No problem. So phenoxybenzamine and phentolamine are not good. But trazosine, doxorubicin are good. Why? Because they block the alpha-1 but they do not block alpha-2. And if they do not block the alpha-2, what will happen? The sympathetic nerve ending will not overfire. The sympathetic nerve ending will not overfire. So this type of tachycardia will not be produced. Am I clear to everyone? Right? So if someone asks you how the alpha blockers reduce blood, first of all, if someone asks you if you want to treat the patient with alpha blockers, you will preferably use non-selective alpha blockers or selective alpha blockers. Selective alpha blockers, right? And how the selective alpha blockers work? Of course, they block alpha-1 receptors. Then what they do? Then you have to tell that this pharmacological action is changing what type of physiological parameter which is reducing the blood pressure. Physiological parameter is, we know, dilation will occur, arteriolar dilation will occur. Mechanisms you know, alright? Blood pressure will go down, right? After that, let's move ahead. Again, let's recap. Sympathetic